Good evening. My name is Sue Ann Sisto, the Chair of Rehabilitation Science. Thank you for attending this evening. And if you are a New York State licensed occupational or physical therapist and would like to obtain continuing education units issued for your attendance this evening, a SurveyMonkey link will be put in the chat after you complete listening to this wonderful lecture. So please be sure to complete all the questions in order to have CEUs issued to you. So thank you, Dr. Skidmore, for joining us this evening to share your important work. We're thrilled that you're being honored as the 2021 Glen E. Gresham Professor, sponsored by the Department of Rehabilitation Science in the School of Public Health and Health Professions here at UB. The Glen E. Gresham Visiting Professorship in Rehabilitation Science features a nationally or internationally recognized authority in the area directly related to rehabilitation science. The late Dr. Al Recate and Mrs. Linda Holt Recate endowed this position in honor of their friend and colleague, Dr. Glen E. Gresham. Dr. Recate played a key role in the creation of UB's School of Health-Related Professions, which ultimately gave rise to this School of Public Health and Health Professions. Dr. Gresham was a cum laude graduate of Harvard University and earned his medical degree from Columbia University. He served the university at Buffalo from 1978 to 1998, including service as chair of the Department of PM&R in the School of Medicine, Biomedical Sciences at the Erie County Medical Center. He developed the first spinal cord injury unit at ECMC and served as its director and set up programs for treatment of post-polio syndrome and traumatic brain injury. Dr. Gresham was a leader in stroke research and served on several federal task forces on stroke rehabilitation. Glen E. Gresham was previously the chair of the Department of Rehabilitation Medicine and has had a strong passion for rehabilitation and research. After meeting with you today, Dr. Skidmore, I'm even more excited to say that your background emulates this very passion. Please allow me to share just a bit of background to the audience of Dr. Skidmore's background. She is a professor and chair at the University of Pittsburgh Department of Occupational Therapy and an associate dean for research. She holds secondary appointments in the School of Medicine, the Department of Physical Medicine and Rehabilitation, the School of Nursing, and the Clinical Science Translational Institute. She is also a scientist at the University of Pittsburgh Medical Center Rehabilitation Institute. Dr. Skidmore has won numerous professional awards, including the American Congress of Rehabilitation Medicine's Deborah Wilkerson Research Career Award and the Presidential Early Career Award for Scientists and Engineers. In 2013, Dr. Skidmore was the first occupational therapist to receive this Presidential Early Career Award, which is the highest honor bestowed by the United States government on early career scientists. Very impressive. She's a fellow of the American Occupational Therapy Association. Dr. Skidmore has publications, book chapters, and invited presentations too numerous to mention. Dr. Skidmore has a strong grant portfolio and has recently completed an R01 grant entitled Closing the Gap in Stroke Rehabilitation, Early Intervention for Cognitive Disability from NIH, NICHD, and is currently a co-investigator on a grant entitled Preventing Cognitive and Functional Decline Among Seniors at Risk, a community-based randomized controlled trial funded by the Canadian Institute of Health Research, similar to our NIH. So without further ado, I'd like to introduce Dr. Elizabeth Gilmore, who would be speaking to us this evening on optimizing rehabilitation for people with acquired brain injury. Dr. Skidmore.
Thank you very much, Dr. Sisto, and to the organizing committee at the University of Buffalo and the School of Public Health, and the Department of Rehabilitation Science for this wonderful honor. It's my pleasure to be with each of you tonight to talk to you about something that I'm very passionate about, and that is how do we optimize rehabilitation to better meet the needs of people with cognitive impairments, whether due to brain injury or stroke or a variety of other conditions. And so I'm going to hop right into it and talk a little bit about what we'll be addressing in the few minutes. My first objective is that we're going to talk about briefly the current state of science on cognitive impairments and their role in rehabilitation, delivery, and outcomes. We're going to describe theoretically informed approaches and related evidence for people with cognitive impairments in rehab settings and how we can use that to optimize how we deliver rehabilitation services, and then discuss let's try one more time, discuss implications for rehabilitation practice as well as future research, because one question begets three questions, as we all know. So for me, the rehabilitation research program in my world starts with my clients. And as I was a practicing occupational therapist, I constantly had this observation about the experience of people who had cognitive impairments in a rehabilitation setting versus those that didn't. So I'm going to tell you a story about this woman who's given me permission to share her story with you. When I met her, she was a retired homemaker living alone. She's a library volunteer. She had 3 children, but they all live outside the state of Pennsylvania. She lived alone. She volunteered at the local library. She drives. She was managing all of her daily routine and had a pretty big social life. But as a result of left CVA, she ended up with some mild weakness in her right arm and leg, some mild to moderate impairments in attention and executive function, mild depressive symptoms, and obviously a loss of independence with mobility and self-care and homemaking. I met her on her first day of inpatient rehabilitation, and when I asked her, what are you hoping to accomplish with your rehab experience? She said, I need to get back to my life. I need to get back to driving and cooking and cleaning and volunteering at the library because people are counting on me. And so when you meet with her, when I met with her, one of the things that's most obvious is she's having a hard time staying alert, staying engaged in the conversation, kind of sitting back in the chair, wanting to get back to home, but not really showing necessarily at first glance all the capacities that she might need in order to do that. So this raises some questions in the minds of us who treat these individuals. And the first thing is, in light of these cognitive impairments and depressive symptoms, is it still possible to help return her home? Can she resume all those activities, driving, preparing her own meals, managing her own medications in light of these cognitive impairments? Or are we doing her a disservice? And my frustration, my clinical itch that triggered my research program was that I had to believe, given all the tools we have in our tool set, that there's got to be a way to do that. But early in my career, 25, 30 years ago, the assumption with someone like her is we probably need to find her a safer living environment. She's probably a nursing home placement, right? And I felt very unsatisfied with that automatic conclusion. So that is what drove me to go back, receive training in my PhD, and build a research program to really tackle these problems. What you may or may not be aware of is that cognitive impairments are incredibly common, are often unassessed or underassessed, and are often undertreated among rehabilitation populations. We know in our minds that people who have stroke or brain injury are likely to have some cognitive impairments, but I'm not sure we've really spent a lot of time thinking about the frequency or the impact of those cognitive impairments, nor tailoring our treatments to best meet their needs. And just to put a little bit of data, this hierarchy is a gross extrapolation of that in the World Health Organization's ICF, the International Classification for Functioning, Disability, and Health. And so we think about arousal, energy, and drive as a requisite to then processing sensation and perceptions, to then focusing on more complex cognitive functions like attention, language, memory, spatial processing, for example. It's not a comprehensive list. And then the peak of our cognitive abilities are our metacognitive awareness, or ability to think about our thinking or think about our behavior, which is a critical function to organizing our behavior, to learning new skills, to adapting new routines, and to sustaining those routines. You may be surprised to learn that in the literature, and even more recently, people have estimated that anywhere from 20 to 50% of people who sustained a stroke probably have cognitive impairment in this second tier. You'll notice that's a very wide estimation, and that's because the investigators have used a variety of different tools. Some are more sensitive, some are less sensitive to detecting cognitive deficits in this tier. But if we use precise measures to really understand metacognitive abilities or executive functions, estimates are as high as 80%. I saw a paper yesterday that says 85% of people who sustain stroke probably have changes in their executive functions. And there's subtle changes that we often don't notice, do not measure, and do not address in our care. So much so that they're referred to as the silent epidemic. Question is, do these matter? Do these have some impact on outcomes? So this is an analysis that I did a few years ago where I looked across our inpatient rehab units. I picked a sample of 212 people admitted for inpatient rehab due to stroke. And then I looked at measures of motor function, global cognitive measures versus executive function measures, measures of mood symptoms, depression, measures, and then we looked at other variables that we think could predict a 6-month FIM score. So this is back when we were still collecting FIM. And after controlling for that baseline admission disability score, or FIM score, which we know is the most robust predictor of later FIM scores, what we found is the two variables that had the strongest relationship with that 6-month score were motor function and executive function, but only executive function was a statistically significant predictor, a stable predictor, accounting for, you know, a fair amount of variance in that 6-month score. And yet we tend to focus more on the motor deficits. So evidence of this silent epidemic. And I'm going to make just a quick ploy. I talked with some people today about their work in spinal cord injury, in critical illness, in cardiac diseases or cardiac arrest. And I would say these findings would generalize. There are data to support these same principles in those populations. And some of those populations are in greater risk because we're not even measuring cognitive function. We're not even thinking about cognitive function. And yet all of those conditions could contribute to executive deficits. Furthermore, we look to see what's the degree to which different clinical symptoms contribute to engagement in the rehab process. My colleague Eric Lenz, who's a geriatric psychiatrist, developed a tool. It's called the Pittsburgh Rehabilitation Participation Scale. It's completed by the occupational, physical, and speech language pathologists who interact with people during inpatient rehab and adjust, and they score how much they feel people actually engage in their rehab process, show effort in every session, show active learning and understanding and carryover of principles. And what we did is then we separately measured attention, memory, executive function, depression, apathy, and then obviously also looked at baseline disability. And what we found is that it was executive function, not depression, not apathy, that were the strongest predictor of that engagement process. And I took that back to the therapist and I said, you guys all had a hypothesis it was going to be depression or apathy. You thought someone's not engaging because they're too depressed or they're not motivated. That's not what our data show. What does this mean? And they said, you know what? It could be that we just weren't even aware they had an executive deficit. So we attributed it to depression or apathy, which I thought was a really interesting observation. And then recently, my PhD student took a separate data set with a couple hundred patients. I think this was around 200 patients as well. She repeated this finding. After looking at stroke severity and disability again, a strong predictor of engagement, executive functions more than visual spatial skills or other cognitive measures, as well as mood, was the most robust predictor. So there's something about executive function that is influencing people's engagement in the rehab process. We're sometimes aware of it, we are sometimes not, and that becomes really interesting. So put simply, I'm often talking to audiences that don't understand what we do in rehabilitation. So I come up with simple ways to make my story. And put simply, people with cognitive impairments have more disability at the time of the onset of whatever injury or illness they have. But they also have a separate problem. They have an attenuated slope of recovery. And the question would be, is that because of the cognitive impairment itself, or is it confounded by the fact that they're not engaging in, learning, or benefiting from their rehabilitation at the same capacity as people without cognitive impairments? And if that's the case, if that's the hypothesis, then that would suggest we got to do something different. Our approach to rehab is not meeting the needs of this population of people with cognitive impairments, and we're creating a disparity of sorts. And so the goal is to close the gap. You recently heard I titled a grant around closing the gap on this basic premise. It also raises some questions. can we alter that trajectory? Is that a modifiable trajectory? Is there something we can do different that changes the slope of recovery? And I intentionally drew this figure as I did because probably that initial cognitive impairment and initial severity of disability is due to whatever insult is happening to the neurological system. That once it's happened, we really can't do much initially to do anything about that. But if we can alter that trajectory of recovery to at least be parallel to that of those without cognitive impairments, that still is a pretty significant potential influence or outcome that we can influence. So that's one question. And then the second question is, can we help these folks be independent despite their cognitive deficits, number one? Number two, are those cognitive impairments persistent, or is there something we can do to actually address the underlying impairment? So this is the premise under which all of my research studies really emerged, and has led to a series of questions, some of which we'll cover tonight. So my goal at large is to promote learning engagement for people with cognitive impairments, first and foremost, to see if we can improve their independence regardless of the cognitive impairment. And potentially, secondly, if we can also improve their cognitive skills, that's just icing on the cake, okay? But the interesting question, the scientific question that's even more important, is not can we find something that works? That's kind of an interesting question, but not the most important. The more interesting question is, what are the active ingredients that drove that change, and how do they work? Because if you understand the active ingredients and you understand how that change came about, what that mechanism is, then you've got a principle that you can simply operationalize and deploy and scale very quickly into practice. And it is evidence-based, and it has great potential for big impact with small moves. So I've spent a lot of time at looking at different active ingredients, testing those mechanisms and trying to understand them. So what works? What do we know? No science is built off of starting from scratch. There's always evidence to draw from to inform and refine our questions, and also to inform and refine our methods. So I had at the time, early on in my career, I could build on a number of systematic reviews and evidence-based meta-analyses. These are just some examples that have been published over the years that have looked at summarizing the evidence on interventions to address outcomes for people with cognitive impairments after brain injury or stroke. And one of the things that I learned from these reviews, and this recent review that was also published in Canada, specifically on executive functions, is that the interventions that I saw really fell into two classes. Interventions that directly address the cognitive impairment or the underlying impairment, with the hope that that would have some benefit for restoring or improving independence with daily activities. And then a second class of interventions that were really much more activity oriented, focusing on the independence. How do I perform those meaningful daily activities with the hope that it would have some sort of trickle down effect to improving cognition? And they kind of fall into these two classes in my mind. And so I started to explore these a bit further. And if you look into these reviews, there have been others that have been published even more recently that give similar findings. What I really learned is that impairment-focused interventions reduce impairment, but they do not necessarily generalize to restore independence. So just having someone do a physical exercise or a cognitive exercise or engage in something that's cognitively stimulating with a drill and repeat type of method actually can address the impairment they're designed to address. Someone can get a stronger muscle through exercise. They can get better cardiovascular resilience through exercise, and certainly exercise. The cognitive training, if it's focused and well designed, can actually improve certain cognitive operations. And there's some evidence to suggest at minimum we can improve processing speed and some other underlying impairments. But just because I think faster on a cognitive test, or I move a muscle with greater efficiency, does not necessarily mean I use those skills in my everyday routines in the midst of complex activities. We have to have a scaffolding that directly addresses that. And so we have to move beyond simple focus on impairment-focused interventions to more activity-focused interventions if we want to address that larger outcome of independence with daily activities. We actually have to practice the activities. We got to find out where the barriers are. What are the contextual or environmental factors that are influencing that? And how can we design the intervention to address those needs? So moving beyond stimulation and exercise to engagement in personally meaningful activities becomes one of the key elements that we've started to study in our interventions if our goal is, or primary outcome is, independence with everyday activities. Best evidence, and I've just summarized some of this, but I'm happy to give references to anyone that wants to go back and check my facts of what I'm giving you here. But best evidence suggests the intervention should have these following elements if the goal is to facilitate learning and the acquisition of independence with meaningful daily activities. First of all, it's got to involve practice and doing. Talking about how I make a meal is not the same as making a meal, right? There's two very different cognitive operations and physical demands and environmental factors, that two different sets of things that can influence that. So it's got to involve doing. It's got to be salient. Our neuroscience evidence tells us that salience actually facilitates engagement and learning. So personally meaningful activities become a really important component of the intervention. It's got to involve some sort of structured goal setting and goal achievement approach. And the degree to which it's client-centered is the degree to which you pull salience into that goal setting and goal achievement. And it's got to have a structured approach to training. So it's not enough to set a goal and then practice a number of different things. You need to be thoughtful about how do we structure practice? How do we provide instruction? How do we provide feedback? How do we involve the client in that process? How do we get them to reflect on their performance so they can improve it? Because again, the goal is that lasting independence and not a reliance or a dependence on one of us. So I'm going to talk to you about two approaches to structured training that I'm going to dive in on a little bit more. And again, this is World According to Skidmore, and it's an oversimplification. I'll be straight with you, just for purposes of illustration. But generally speaking, when I look at skill-based, activity-based training approaches, they fall into two categories in my mind. And those are direct skill training, where we identify a problem, we work with the client, and we give them the strategy that we want them to use to address that problem. So the therapist often selects the activity. The client may set the goal, but the therapist decides what we're going to work on in the session. The therapist assesses that performance and says, okay, these are a few things I want us to work on. The therapist derives the strategy, delivers and trains on that strategy, drills and repeats on that strategy, directs the practice. And then at the end, okay, so this is what we saw, this is what you're going to do next time, and really summarizes that learning. And this is a very effective approach for skill retention. To learn a new skill and to retain it over time, direct skill training has a role in our practice, okay? But I'll show you some data in a moment. This is about 95% of what we see going on in OT-PT clinics that we've sampled across the nation. About 95% of it. And it may be one of the reasons this approach may be not meeting the needs of people with cognitive impairments. It may be one of the reasons why we see this disparity in outcome. At least that's a hypothesis that we're testing. The second approach I'm just going to refer to broadly as a class of interventions that focus on strategy training. And in strategy training, one of the core elements is guided discovery, which I'll unpack for you in a moment. But guided discovery is really focused on taking the therapist out of the role of a direct skill teacher and putting the therapist in the role of coach or facilitator, where we're eliciting the client's awareness of their own performance and getting them to develop and derive strategies and getting them to evaluate and apply those strategies and getting them to think about how they would summarize or apply that learning to another scenario. So rather than I'm going to tell you what to do, it's going to be, let's work together and see if we can sort this out. So it's a very structured approach. It's not discovery learning, which I'll describe in a moment, where you just say, try it and let's see what happens. It's actually a very structured approach, and it takes all of the skills of a trained therapist to implement. The client, though, selects the activities, and we use a structured approach for that so we can ensure that we're going to meet the goals that we are seeking to achieve. The client assesses that performance, tells us what they think went wrong, and sometimes they identify things that we think aren't that big of a deal, but they miss the things that we think are really important. And I'm going to tell you, after looking at 300 patients and thousands of hours of video, it doesn't matter. It really doesn't matter. It's the process of self-awareness and self-monitoring that gets the client to start to identify breakdowns in their performance, and that's the skill that generalizes. The client derives a strategy. All right, this is the problem I've identified, so this is a strategy I'm going to come up with to address that problem. Then they direct the practice, they decide how to plan it and move forward, but the therapist structures that to ensure safe execution, asks questions about what could go wrong here, how can we account for that, and we bring the client along with us in our reasoning process. We make it out loud and obvious for them so they can travel with us down that journey. And then the client at the end of the day, what did you learn from this? Is there anything you could apply to tomorrow? What kind of activities can you do? And they summarize that learning. And there's some great evidence. I'm not going to have a chance to show all of this, but I can give you some evidence out of Toronto as well as St. Louis that have shown that this actually does lead to better generalization. Some would argue some of my data also suggests there's some generalization, but I'll let you judge. I'm not sure I buy it, so we'll talk about that later. So both of these approaches have a role in practice. I want to be very clear. One is not better than the other. They have specific purposes and implications for applying, and we've started to test an algorithm that would argue when you use one versus the other. And if we have time for that, to discuss that in questions, I would love to talk about that more in the discussion at the end. But I can tell you that our approach to the structured training, whether we use direct skill training or guided discovery, could actually influence the trajectory of recovery. This is a slide that actually I borrowed from my colleague, Sarah McEwen, who's a physical therapist in Canada, who talks about the therapist control continuum here, where on the bottom left here, you see discovery learning, where the therapist has very low control. And this is kind of, let's try it and see what happens. If you think about someone who's recently had a stroke or a brain injury and you say, all right, try getting out of bed, see how that goes. That's probably not a great strategy, right? And a lot of people think that guided discovery is this discovery learning, and it is not. I'm going to make that contrast so you can see the difference. We know from research over many years in K through 12 education, higher education, adult learning models, psychological studies, that discovery learning is a completely ineffective way to learn, whether you're an adult or a child, whether you have a disability or you don't, whether you have a cognitive impairment or you don't, nobody learns in an unstructured environment. We get exposure, we get stimulation, but we don't learn. We do not learn new skills in that environment. So that is not what I'm talking about. But the other approach, as you move up the continuum, is guided discovery, where there's moderate control, shared control with the client in assessing and directing performance, directing practice and applying that practice. So let's try it together. Let's plan it out. Let's think about what might go wrong. Let's account for that. And then I'm going to help you if you get stuck, okay? And I'll illustrate this with video in a moment. Versus at the very high end of the control, where the therapist is really directing that care, right? You said you wanted to work on golfing, so we're going to set up this task and we're going to simulate your golf swing. That's an example of a therapist-directed selection of an activity in the treatment session. And the therapist really drives that process, as I told you about before. Again, I would argue that they both have a place in our practice, but the question is how much and when and for what circumstances. So these are some questions we've started to design some studies to get to the bottom of. So one of the things that right off the bat we learned, we designed a study where everybody got either direct skill training, they got direct skill training or guided training. Both groups developed their own client selected goals. Both groups did some evaluation of performance. Both groups came up with a strategy, and both groups practiced those strategies and tried to generalize learning. The only difference is whether the therapist drove that process or the client drove the process. And so we said that this is probably an estimation of one element of strategy training, the guided discovery element alone, not all the client selected goals, not all the other elements, just the guided discovery. And so in this study, we looked at FIM change over time, baseline through month 12. And what we found is during the rehab process, we didn't really see much difference between groups, but over time, the groups started to separate. And the group that received guided training or strategy training is the solid black line. The group that received direct skill training is the dotted black line. And the group that received a control condition, essentially usual practice without either guided or direct skill training, actually did worse than both. And that's a historical comparator. That was not a randomized control. We pulled it from some historical data and matched based on baseline characteristics, okay? So we still saw this difference at 12 months of a meaningful, clinically meaningful difference in the FIM. But I think the more interesting thing is we started to see this effect size of difference. So this is a moderate effect size of difference in change scores at month 6, and a moderate effect size of a difference in change scores in month 12. Again, this isn't a test of strategy training versus usual care. This is a test of strategy training with guided discovery versus the same ingredients, but the therapist is driving the decisions and the practice. And so we see this as that maybe guided discovery alone, that one active ingredient is probably driving maybe a moderate effect size of difference. Then we look to see the degree to which we saw that ingredient in usual practice. So what we did is we videotaped, this is 20 participants. They all received strategy training in addition to usual occupational therapy and physical therapy. We videotaped sample sessions from the strategy training session as well as OT and PT during inpatient rehab. And then we had an independent coder who was not part of the study go in and use a coded scheme that we had previously developed and validated and published and look to see how much we saw guiding occur in the sessions versus how much we saw directing. And directing, we realized, kind of fell into two types of directing: verbal cues, put your foot here, versus we do a lot of touching on our clients, gestural cues or pointing or touching, moving their leg or locking their brake for them. And we coded all of those cues in these videos. And what we found is in strategy training, in fact, in years, I used to say, I don't know how much guided discovery is enough, but I feel like it might need to be 40 or 50%. If we got to just more guided discovery than what we're doing in usual practice, that might be good. It turned out it was about 40% of our strategy training sessions involved guided cues versus directed cues. Whereas in usual care, it was less than 5% in both OT and PT. We also looked at speech language pathology, just to be clear for those of you that are present, but not all 20 received SLP speech in our inpatient unit. And so it wasn't a good comparison of apples to oranges, but it was still a very small fraction. It was about 5%. I think it ended up being 9 of the 20 patients here. So that's one thing. The other thing is, if you look at the solid red line on the right, is the amount of guided cues that we had varied from patient to patient, which would suggest that we are sliding up and down that therapist control continuum based on how much cognitive impairment we see, the type of task that they're attempting, the safety risk, the environmental factors, a number of different things. And so we saw highly trained strategy training therapists go as low as 20%, and in some cases as high as 80% guiding, giving the client way more control in that case versus in other cases less control. So it varies, whereas we saw less variation among those in the usual care sessions. So this particular ingredient I'm going to demonstrate for you in a moment, but it kind of illustrates the contrast between guided discovery and direct skill training. So let's take a moment and dive a little bit deeper into these and operationalize these so that you have a better understanding of what I'm talking about. So I told you that direct skill training teaches clients the strategies that are developed by a therapist. And, you know, a lot of our task-specific training approaches, this is the approach we take. Again, it's not inherently bad. It has a time and a place. But often what we're doing as a therapist is we identify a problematic task, we break it into steps, we teach the client one step at a time, they repeat the instruction, maybe we start to withdraw our support as they start to perform. Once they master it, we go on to the next step and we chain steps together. That's one example of a direct skill training approach. And I have a video of a therapist working with a client who's intentionally using a very rigorous direct skill training protocol from that previous study I told you about. So we protocolized that, we implemented it, we ensured fidelity to that approach, and she's doing exactly what I'm asking you to do. And for those of you OTs, you're going to recognize hemi dressing technique here. That's what you're going to see her working on with him.
So with this hand, which is my right hand as well, you have to do more of this. See underneath? And bringing it back towards the elbow, right? Okay. And then you grab here and back towards the elbow. See how we're getting it towards the sleeve? Yes. Excellent. Okay, now again, grab back here and pull back towards the elbow. Hold on. Yep. Ah. Now, all you have to do is get the right arm in there. Your time. I would move and pull this fabric on the left past the elbow now. Yes. Is it there? Yep, good idea. Okay.
So you get the idea. She's developed the strategy and she's given him the strategy. She's repeating it to see if he understands it, and he's demonstrated his understanding by following through. Asking you, even though I know you can't answer me, how effective is this approach, do you think? How much do you think he's learning how to approach hemi dressing, getting his arm in? It's something to ponder on. And one of the things that I think about often is how often we spend so much time repeating ourselves, saying the same thing again and again. And we think the person that catches on is the person that's engaging, and the person that's not catching on is just not invested, right? That's tends to be the way we look at it. I look at it differently now. I'm not sure that strategy has any meaning to him. And having worked with people, and I figure I rather than giving them heavy dressing technique, and we use a strategy training approach, and I ask them, how are you going to get your arm on? They use a whole slew of creative strategies that I never would have thought of. And half of them are ugly and crazy, and all of them work just about with practice. And they own the strategy. It becomes a part of their world. And as long as they're not unsafe, let's proceed. So it's one of the things that I think about is how are we using the time that we're spending with our clients? Is it us talking and handing out our view of the world? Or are we really taking a moment to understand what matters to them, how they might approach it, and then helping to shape that to their advantage? And I think that's something we can all pause and reflect on. So I've talked a lot about strategy training. Strategy training is actually not a new concept. It's been in the literature since the 1940s. It's been used in behavioral modification. It's been used in quality improvement studies. It's been used in business. It's been used in sports psychology. All of these strategies have been operationalized in a variety of different nuanced ways. We essentially went looking for a strategy that had really clear operationalized ingredients that we could apply in an efficient manner in a tight length of stay in an inpatient rehab unit. And we reached out to Helen Politeco, who's an occupational therapist in Toronto. She actually works with children with developmental coordination disorder or bimanual coordination issues, who also have executive impairments. It's one of the common soliloquy that come with that. And she developed an intervention she called co-op, and it's a very OT name. It's a cognitive orientation to daily occupational performance. But it was getting people to think about what they're doing with their daily activities and how they're structuring their approach and how they could use that to leverage better approaches. And we borrowed heavily from co-op. We simplified it for our purposes. She has like 8 active ingredients. You're going to see 4 here. And she has a lot of different operationalized strategies. We didn't spend a lot of time doing that because we needed something we could scale very quickly to practice with people who had more cognitive burden than she was typically working with. So the 4 ingredients of strategy training as operationalized in my lab are self-selected goals. And I'm going to walk through how we get to those in a moment. A self-evaluation process, and I'll demonstrate that for you. A global strategy training process where we teach them one strategy to apply to any problem they come up with that they can operationalize and break down their approach. And then guided discovery or guided problem solving, where the therapist is not telling the clients what to do, but eliciting suggestions from the client and helping to shape those to their advantage. And again, our primary goal, first and foremost, was independence with daily activities. So this is the co-op approach. They have their own academy. They have their own website to provide it for you. They recently published a book. I am a co-author, but I get no royalties by sharing this with you. They've looked at this application in a variety of conditions, including above and beyond stroke across the age span. So pediatric conditions, adult and older adult conditions, neurological conditions, non-neurological conditions. And they've also included not only the evidence in the first half of the book, but the how-to in the second half of the book. So if this is something you're interested in and not aware of, I do think it's a good resource, but I get no kickback if you choose to do that. So let me walk through these ingredients. The self-selected goals have to be done in a structured way. Many therapists, when I ask them, how do you approach goal setting? They're like, well, I just ask, what are your goals for therapy? And they say, and the client doesn't know what to say. And all I get is, I want to go home, I want to walk, I want to move my arm. And my answer to that is, it's because you're treating goal setting as a quick activity. It's actually a therapeutic activity. You can bill for it as a therapeutic activity. It's not an evaluation task, and you have to invest in it. So we actually invest a whole session in goal setting. So we want them to identify and prioritize activities. You remember I told you that the neuroscience will tell us that salience, personally meaningful activities stimulate learning and engagement. We've got to get them engaged and learning first and foremost before we can work on practice and skill acquisition, as well as retention and generalization. We make a requirement that the goals have to be activity focused. And what I mean by that, it's got to be an activity of daily living of some sort, anywhere along the scale. It can be complex ADLs, IADLs, self-care, mobility. We don't really care, but it's not going to necessarily be something about how I move or how I speak. We use other strategies to address those, okay? And they've got to be something we can practice right now in the inpatient rehab unit. We've got to be able to bring in equipment and do it. And we, you know, my people are known on the unit because they're always the one with the big bags, bringing in the hockey sticks and all the different things that people want to practice with. We're all about that. We've used a couple of different approaches over the years to get at goals. There are two structured approaches that are used a lot in occupational therapy, but we've trained every discipline in administering this. And I can tell you our physical therapy and speech language pathology colleagues love these tools. It's been fun to watch them learn about them and like, ooh, I want to use that. The Canadian Occupational Performance Measure, I'll start with that first. It's just a structured interview. And we go through kind of categories of activities. We start by asking people to tell us what a typical weekday looks like in their routines, what a typical Saturday and what a typical Sunday looks like, because weekend routines vary, right? And then we ask them to go through that while loading their working memory. What did life look like before my stroke or my spinal cord injury or my brain injury? And thinking through that, what are some of the activities that you were doing before that are meaningful to you that we want to work on? And then we use categories to try to pull those out. And from there, we were selecting 4 to 5 goals, activities to work on as a focused effort in the strategy training sessions. That actually worked okay. And that is the way it's done in co-op. But my people have a lot more cognitive impairment. It was a little harder for them. So we changed up to something, a tool called the activity card sort. And I was looking to see if I had a photo in here. I don't think I included one. But the activity card sort, right now, it's about 100 cards. And it's got people doing all different kinds of activities in the home, in the community. And they're crazy all over the place activities. And we have them sort them into things that are meaningful to me, things that are not. And then sorting things I want to work on in rehab and things are not. And then pick 4 to 5 and tell us why they picked those 4 to 5. Why are those meaningful to you? And the activity card sort brings out this engagement that's a whole different thing than when we interview people. So we actually have no problem getting goals from clients. We have problem getting them to narrow them down. That's the bigger problem. And so, but they come up with great activities. And so like in olden days, when I would ask people, what I would get is, oh, I want to be able to move. I want to be able to walk. I want to be able to move my arm. I want to be able to go home. Now we get goals like, I need to stand at the sink and brush my teeth using a water pick and my right hand, my weak right hand, right? Very specific goals. I want to be able to prepare simple meals that I only need the stove or the microwave. I want to organize my medications without assistance. I don't want anybody taking care of that for me. I need to be able to take a shower, but the problem is I have to get in the tub. We don't have to elicit that from them. The activity card sort does it automatically, because the minute they start seeing these pictures of people doing things, they start thinking about, oh yeah, that's really meaningful. But in my case, it's this. And so we get these great. I had a gentleman who had just had a baby right before his stroke. And he's like, I got to be the one that diapers. I'm going to be stay-at-home dad for a while. That was originally the plan. I got to be able to do the diapers. So the goals they come up with are so practical. They're so meaningful. And it's not groom, you know, with setup. It's actually really cool stuff. And we can document on this very easily. We can bill for these services very easily. So these are actually the goals that my lady came up with, and they were pretty ambitious goals based on my first visit with her, given that I had to keep nudging her and keep her awake through the session and keep her engaged. But the minute I pull out that activity card sort, her little lights started to come on and she started to get engaged. So that was a big thing. So what I'm going to do in a moment is show you what this looks like. Once we have identified the activity, we're going to sit down and talk about, all right, when we get ready to do this, what's it going to look like? What could go wrong? Where are you at risk? How can we plan for that? So we're going to actually try it. We're going to move right from picking the task to doing the task, okay? But we're going to give her a little bit of control in how we do it, she going to stand? Is she going to sit? Because I need to plan differently based on her capacity and the environment and so forth. So we're going to involve her in that process. And we want to get her to trying the activity as quickly as possible, because we want her to be able to tell us what went right and what went wrong, rather than us guessing or us telling her what we observed. We want her to start to self-monitor. This is key for people with cognitive impairments. We assume they can't. I'm here to tell you they not only can, but it actually improves their awareness of what they can and cannot do. So we want to get to doing as quickly as possible, not a lot of talking about it, but we want to structure that initial practice. So even if it's ugly, it's safe, okay? And I'll show you a good example of ugly. And then once we do, we might elicit some ideas about their observation of the performance. And then we're going to try it again and again and again and repeat this process. So here she is. She's selected her activity. This water pick is really important to her. So we got it in from home. One of her friends brought it in from home and we set it up. And she talked a little bit in advance. She's like, I think you're going to have to put it on a bedside table because that sink in there is not so great. And I'm going to try to stand. So the therapist is prepared for what may go wrong and she's ready to go. Okay. So we're going to try it.
All righty.
Okay.
I'm ready when you are.
I'll get up. Okay. Now, you know I'm only takes 2 hands for this, so I kind of have to.
You take your time. And
Get over it. I'll put it in my mouth, and what you do is press this button here.
do you think you can do that?
Yeah. I don't know. I only have one hand. If I hold this, this is the bad hand. If I use that way, I'd have to cross over. It's going to spray all over.
Uh-oh, didn't go as planned.
Wonder if this outlet's working,
I
huh?
think there's that little plug underneath your throwing thing that's pressed in. Press it in. You see it?
Yeah.
Emily, who's now a tenured faculty member, she was a PhD student at this time, hates it when I use this video, but I use it intentionally. And the point here is never miss an opportunity. Here, things didn't go as planned. Guess what? At home, when you're not around, things aren't going to go as planned as well. Don't make it about what it was supposed to be. Use the problem that occurs and work through the strategy with them. So a couple things that you observe in this video is you got Emily ready in case her balance isn't awesome, so she's ready. Meanwhile, this woman's doing this self-dialogue. You're going to have to press the button, and Emily says, why don't you try to do it? Right? Because the whole point was to set her up for independence. And she's like, I can't, I got to hold it with this hand. It's going to spray all over. And Emily does this wonderful, because the worst case scenario, she's done the math, they're both going to get wet. Okay, no biggie. She's not going to fall. She's not going to hurt herself. And the more we give her a chance for a little bit of errorful learning, errorful experience, the more likely she's going to be able to get a sense of what she can and cannot do and how to set boundaries at home. So here they go. They sat there, they tried it. Now what we're going to do is teach her this strategy. The strategy we used to use was a strategy called goal, plan, do, check. That's what's used in co-op. We found that the goal language got kind of confusing for clients. They didn't really understand that. That makes sense to us, but it's not their word. So I met with some really smart PhD students and they came up with the START strategy. And we just started using this on our last 2 studies. START, select an activity, try and assess it, reflect on a plan, try and debrief. And so that is the strategy they learn. We've got to start, they learn these words, and they learn to apply this strategy again and again and again until they master it. It doesn't really matter what activities we're using, how they go, how they don't go, it's practicing the strategy. And once they start using this language, all of a sudden they realize it wasn't my bad hand, I didn't have a good plan. It wasn't the fact that I can't stand, it was I didn't set up the environment the right way. And they start to change their focus on what they can manage. And so this has been a really important, and the strategy is not magical. It just provides a structure for learning. So the therapist isn't having to do the thinking for the client. The client has something to pivot from to start thinking about how they're going to go work through the problem. So you're going to see them working through a debrief here and then revising the plan.
Did we do the plan that we came up with?
That's right.
Okay. So we tried to do the plan. Okay, and what worked well and what didn't work well about the plan?
Oh, there you
What
go.
happened?
I like you got it.
That was not compatible.
Okay.
Not sure that's it. Doesn't really matter.
The table, a
Sure.
table that's
Did the
built.
table work well, do you think?
I think you could probably bring that up, and it would be,
Okay.
yeah.
All right, so we'll need a, if the sink is small like that one, we'll need a
Yeah,
table. Okay,
at least
so
on the same height, I would imagine, table
Okay.
or shelf.
table or shelf to hold the water pick then?
Or a sink if it's, the sink is
If it's,
big enough.
So you hear
Sure,
this kind
larger
of
like this.
fluency of ideas?
okay,
Very different from the first day I met her.
all right. Now we have to decide what the next step is.
We're gonna ask somebody,
Okay,
have plug for the outside Aphasia.
All right
Okay.
then.
And then maybe you'll direct us to look for at least, I think the ones that are numbered must be special ones.
okay, so we're gonna ask, do you have any ideas?
I think you could ask the nurse,
Okay,
the head nurse,
okay,
she should be able to tell us.
sure. And, are you gonna do that or am I gonna do that?
You do that, I
Me?
think
Okay.
you're free.
Sure, I will do it. I just want to check with you what the
Yeah,
plan
no,
was.
I designate.
So she goes from, okay, honey, that sounds really nice, whatever you say, trying to keep her awake, to I designate. And one of the fun things that happened with her, we hear this a lot, but I remember in particular with her, is she went to physical therapy the next day and said, I know you got some kind of plan, because this was being offered in addition to their usual care. So they're still getting usual OT-PT sessions. And she said, but I've got a goal that I want to work on, and I'd really like to work on this. Can you show me how to get on and off the floor? And I love the physical therapist response. That is a really cool idea. Let's tackle that. So she went from someone who was passive, many people thought was not motivated, depressed, not engaged, to all of a sudden the team's like, you know what, I don't think we needed a nursing home placement. I think we could send her home with some support and she'd probably be okay, because she started to engage. What we were working on mattered to her and she started to engage. So I'm going to show you one more time what it looked like when she, we've seen some examples of some guided discovery. One of the things that I think Emily did a really good job is giving her room, because she was eliciting ideas. They might not have been the things that Emily thought were most important. She probably was worried about the posture. She was probably worried about what she was doing with that hand and whether she had enough control to control the wand. But it doesn't really matter, because the client was safe, and what we're going to do is get her up and practice again. And we've learned that practice brings about better performance anyway, and I'll show that to you. So the goal is to ensure the client to solve the problem, but it's not just sit back and let them figure it out. We're going to question, we're going to coach. We might even say, you know what? If I think about it, these are some things that could go wrong. We really need to come up with a plan to address those issues if it's not obvious to the client. We start with the least directive instruction, but we slide up the continuum to more directive if needed. And I think the key is using the strategy to get the client to direct the process, but the therapist is guiding it to ensure. Helen Politeco talks about the core cardinal rules of guided discovery. Only focus on one thing at a time. Don't get them to solve more than one problem or address more than one issue. Practice will take care of that for you. Ask first rather than telling. If that doesn't work, coach rather than adjust. I don't know how many times I've had to slap the therapist's hands to stop adjusting wheelchairs, brakes, setting up the table for the client. Let them learn what they need to do so that they can do that for themselves, or direct someone to do it for them. And then if all those three things don't work, then make it obvious. I'm not saying don't do that, but make that your last solution. See if they can elicit this awareness on their own. And so this is the next day after they've come up with their new plan. One of the things that's not on the video that they talked about is, let's see if we can find a different setup so that you're working with the water pick on the other side. So you'll see this is the very next day. Automatically look at how she's standing now versus the first time.
I think I can take the whole reservoir home.
Okay.
Look at her confidence. It's crazy, right? One day. Yesterday, she didn't want to hold the wand. Today, she initiated holding a tub of water with that right hand. This is what I mean. We don't necessarily have to point these things out. Clients start to figure it out on their own.
2 minutes overall.
Oh, I'm in no rush at all, so
Okay.
you take your time. Don't rush on account of me.
Well, first time we'll do it this way, okay?
in charge. All right, not perfect, but look at her try to use that right hand and then develop different strategies on how to control that line. She did not learn non-ring non-use. So this is just a good example. And one of the things that we find is we spend less time and we get more gains faster with this approach in inpatient rehab. We've also seen it in our outpatient and our community-based studies. So we've done a series of studies over the last 14 years. We've run over 600 people through, 300 of those have received strategy training. We initially had to show that it was feasible to do this in inpatient rehab, and then we had to look at how do we operationalize the protocol? How do we establish fidelity of the protocol? Can we do it within the existing time and space provided by clinical practice? Do we need special equipment or additional time? In our early studies, our average sessions were running about 42 minutes. Now they're running closer to 25 minutes. So it's not taking up a whole session, it's a portion of a session. And we've had really high fidelity. Patients love this approach. I had one lady write a letter to the IRB praising us for our wonderful approach to research. So it's definitely something, and we've had no adverse events in this condition. No falls, no injuries. Because I think with errorful, safe, guided practice, people start to learn where they can move and where they can't. We determined about 10 sessions was the right dose. We've done a number of studies to replicate that finding. We showed that relative to, in addition to, both conditions were provided in addition to usual rehab, they received 1 additional session per day. The strategy training participants are in black circles. The reflective listening was just a control condition where we sent somebody in to ask them what went well, what did not go well in therapy, how are they feeling about it. We offered no active problem-solving ingredients. And if they would ask us a direct, how do I address? We'd say, that's great. Let's write it down in your workbook and discuss it with your team tomorrow. So they were getting no additional support from us. This was an initial, very small pilot study. And what we found was that we had difference was actually quite a meaningful difference. So these folks received on average about 9 sessions. We're aiming for 10, so we did pretty well. Both groups were fairly equal in their exposure. And then we looked at the effect size of difference. And we had a large effect size of difference at both month 3 and month 6. You'll notice again, we don't see difference during inpatient rehab. It happens over time. And this is what some people have argued is generalization. I think it just takes a while for learning-based interventions to take effect, is my personal view. But it's very different from exercise trials where you see a big difference during the intervention and then the fall-off happens when you withdraw that intervention. So there's something qualitatively different. And the difference at the end was a very clinically meaningful difference. People required less than 1 hour less caregiver support for basic self-care and mobility per day in this small pilot trial, which were the pilot data for the 6-site multi-site study that Dr. Sisto mentioned earlier that we just wrapped up. We randomized 225 people and we're in the process of doing those analyses. We've not broken the blind yet, so I can't share that with you. The other thing we found is that people with poor self-awareness did just as well with strategy training as people with good self-awareness, which is one of the things that was surprising. We found that if you look at the dotted black line versus the dashed gray line, those are both groups, very small numbers, I'll admit, who had poor self-awareness, but it seemed to matter whether you got strategy training or not. We have replicated this finding in a larger trial where the error bars no longer overlap, and we see a similar pattern. It's a slower trajectory for people with poor self-awareness, but they end up generally around the same place. Interestingly enough, when I wrote my first grant, you can probably find this even in some publications, I said strategy training will help people with cognitive impairments become more independent for the following reasons, but it's not robust enough to address cognitive function. But I work with a really smart neuropsychologist and she said, measure it anyway. What we found is that both groups got equally better in attention, memory, language, and visual spatial function, but the strategy training group had significantly greater improvements in executive functions, which is a really startling finding. Again, I included the ends here so you can see these are really small ends. And so in our large multi-site trial, our primary hypothesis was, do we see a difference in independence? And our secondary hypothesis, an exploratory hypothesis, do we see a difference in executive functions? So maybe in a week, I'll have an answer to that question once the statistician breaks the blind. But right now it's looking promising, okay? And then what we looked at is that people with strategy training had low apathy and maintained low levels of apathy over time. Lower is better in this case. And we think that's because it stimulates the initiation of goal-directed action. And what you see in the dotted line, the control group, they actually follow the typical pattern post-stroke. People tend to see an increase in apathy symptoms that doesn't level out to pre-stroke levels. So that looks what it looks like in epidemiological studies. Strategy training participants maintain low levels. And then we did some tests to see, can people with aphasia participate in this intervention? We worked with some speech language pathologists to adapt the strategy training program using supported communication principles, or Lang's work up from Canada. And we found that people with aphasia, when we matched on baseline disability, NIH stroke scale severity, they actually had a same trajectory response to strategy training, whether they had aphasia or not aphasia. The blue dotted line are people that received, I'm sorry, the usual care is the blue line. The dotted line, I'm going to get this wrong. Both blue lines are people without aphasia. The people with aphasia are red. However, strategy training is not indicated for a couple of populations. Not indicated for people with moderate to severe dementia because they have enough semantic memory problems that they can't remember and apply and generalize the strategy. It's also not indicated for people who have lesions in certain regions of interest. We actually did an analysis with a neuroradiologist of our data. There were over 200 people included in this analysis, and it was a secondary analysis of intact data, and we found that people who had lesions not in the regions of interest did better with strategy training than in the control condition. But people who had lesions in the region of interest, which were the nucleus accumbens, the anterior cingulate, and the dorsolateral thalamus, those are areas associated with initiation of goal-directed action. If those were knocked out by the stroke lesion, they did not respond to treatment. So those are folks. Now, they're a very small portion, about 7% of people who've had strokes have lesions in those areas. So they're not a prevalent population, but this would not be a good idea for those people. Then we looked at, could we implement strategy training in the flow of visual care? Everything I showed you at this point was an augmentation. And what we found was that we actually could do this in embedding in a usual care. We just partnered with a health system. We observed their usual practice for 3 months. Then we trained them in strategy training, and then we looked at what impact that had on the flow of care, the delivery of care, as well as outcomes. And so these are data hot off the press. You're the first audience to see these. What we found is that in phase 1, usual care, not a lot of focus on meaningful actions, meaningful activities, much more what we would call purposeful or preparatory activities, where we're doing tasks, but they're not necessarily tasks the clients have picked or are meaningful to them. Or preparatory activities, which are much more range of motion, strengthening, modalities, and so forth. And so what we found is in phase 2, much higher emphasis on meaningful activities, nice emphasis on talking and listening. And you also see this increase in other, that was caregiver training. Caregiver training went way up with strategy training because it's a natural fit with what we're doing. So this was the difference between pre and post. And then we looked at within the physical therapy practice, the occupational therapy practice, and the speech language therapy practice, did our guiding versus directed cues change? And I'm happy to tell you that we saw a major shift from directed cues to guided cues from phase 1 to phase 2, and total cues per session generally came down, which is also good. So this is that was physical therapy, this is occupational therapy, and this is speech language pathology. We found that strategy training was associated with an acceptable length. Our actual strategy training sessions in phase 2 were about 20 minutes to 25 minutes. So they ended up being a portion of the session that OT or PT were delivering. So very feasibly fit. We found that patient satisfaction scores, the total score is 32 on this scale, this client satisfaction scale. They were happy in phase 1, they were still happy in phase 2. So that's good. We didn't lose some of them. And our fidelity for a pragmatic trial was pretty darn good, about 8% fidelity before we trained them. And then we almost got to an 80% benchmark during the pandemic, which I take as a win. We got to 77% fidelity in usual practice. That's under non-controlled conditions. And our average total minutes per day, they went up a little bit. Most people felt that what they did is they absorbed most of that in individual minutes. They decreased their concurrent and their group minutes in order to get this in, but ended up being about 8 extra minutes across the length of stay. total 8 minutes across the entire 17-day length of stay in this case. We matched 55 participants from phase 2 to phase 1 based on rehab impairment care category and their baseline GG score. So you can see here we did a pretty good job matching. And what we found is the change scores, we actually exceeded minimally detectable change just within rehab. Keep in mind, my previous studies, we saw no difference between groups during inpatient rehab. Here we started to see a separation. It's not statistically significant yet, but it's associated with a respectable or modest effect size. The other thing that we saw is that we got much more dose in this model than in the previous model. We were administering 10 sessions. People received strategy training 1 to 2 sessions per day because the PT, OT, and speech therapists were all delivering it. And for 5 days a week. So we were getting on average 13 days of strategy training, which multiple doses per day. So that might explain why we're starting to see a distinction here in this small sample. And our length of stay, these are long, but this is a little bit of an artifact of the pandemic. People who probably would have gone to skilled nursing facilities were being admitted in patient rehab. They were sicker. We definitely saw a statistically significant difference in comorbidity. And yet we saw this better effect, which is really interesting. So we did some structured interviews, therapists. This was from OT, PT, and speech team that we trained. They really thought it was very feasible, very effective. And they also gave us some ideas that when we get ready to roll this out into an implementation trial, what are some things we're needing to think about in terms of implementation strategies? So this is from the OT. One of the biggest takeaways was having a better understanding of the cognitive abilities of my patients. Actually, this is a speech therapist. She said it was fascinating to listen to them plan before I actually let them do it. It was eye-opening, exposed patients who had cognitive problems that I previously would not have recognized. That's what she was saying. We also found that this is from the OT. It provides structure, fits easily in the typical tasks that we address. I learned a very clear way to implement learning principles more effectively, realized I wasn't doing so in the past. I thought I wasn't. We hear that a lot. More importantly, I learned to let go of the reins a bit more, let the patients decide what's done on their therapy. And this was a challenge for me, but I found it to be more rewarding. I also learned that quality over quantity can be way more effective. More activities is not always better. Taking time to have those conversations, and she means those debriefs, really was worth it. So less is more in this case. This is from our physical therapist. I saw much better carryover addressing these deficits across PT and OT sessions. I also learned that it's okay to stray from typical models. For some patients, you're still going to see progress that you want to see. And I don't recall who this was. Strategy training with at least one other discipline is monumental, so collaborating was key. Oftentimes we relied on each other to bounce ideas and problem solve challenging patients. And interdisciplinary communication was at its best. I would say this was the best interdisciplinary team I've worked with in a long time. They were already good before we came in, but they actually elevated it to a whole new level by using strategy training as a platform for discussing the challenges they were facing, the successes that they were seeing. So is it feasible, I asked you, for someone like this who was already slated for nursing home placement on day 1 to actually go home? She was a success story. She actually returned home in place of a nursing home placement because she started taking charge. She still had mild impairments in executive function and coordination, some balance. They sent in someone to cook meals for her twice a week and someone to assist her with bathing. But as a 2-year follow-up, she still stayed home. So even if she was admitted the next day, we call that a victory. That's 2 more years in her home, living independently, and she did very well. However, there are a lot of questions. We really need to start looking at effectiveness, adoption, and sustainability. We have some trials underway. They're pilots for a larger implementation trial. We're working with a Center on Implementation Science to actually design a collaborative multi-site implementation. So we're doing randomized trials right now. We've been starting to work on some hybrid intervention implementation trial pilots. And we've been looking at adaptation for outpatient and community-based settings. So that's work underway right now. And I still don't think we've answered all the questions for a given person. What's the best time and what's the best delivery? When does direct skill training make sense? When does strategy training make sense? And how do we train therapists to make that switch back and forth in their minds when they're working with clients? Because I can tell you, once people learn strategy training, it's really hard to unlearn it for them. This has been funded by a boatload of these studies. Majority of these I've served as the lead investigator on, and we've used a combined federal and local dollars as well as industry dollars to move this research forward. But these are really the heroes. On the top as the research scientist, she's a PhD trained scientist, Dr. She coordinates my lab and works with me in overseeing the staff, coordinating our studies, as well as doing her own science. Lauren is a statistician and clinical trial methodologist. Jolene Radakowski leads the work right now. She's doing work in MCI and mild dementia and finding very promising findings there, just not in moderate to severe. And she's leading an R01 right now funded by the NIA. She's a tenured faculty member. Naor is a postdoc from Israel that's doing some work. And Laura and Kara are research staff that worked in my lab over the years. And along the bottom are all PhD students. The first 5 have all graduated and the last 2 are in process. So these are therapists that have worked with us to work with the other therapists that are employed in the health systems to help us understand what's working, what's not working, how do we make this more feasible, scalable, what are some ways we can monitor it. And then I included some key collaborators from Pitt, Toronto, and Duquesne that have been really a part of this work. So I think we're doing okay. I've got about 20 minutes for questions. I'll stop there.
Okay, thank you so much for a wonderful talk. And it seems like you barely took a breath. You're doing so much. It's amazing. So we do have one question so far. Just make sure I get this right. Okay, so do patients with MCI or dementia have issues related to remembering the tasks? And I think you almost answered this, even if they got this type of training over time. And do you need to reinforce over time, or any ideas how to help these patients?
Yeah, it's a really good question. So Jolene Radakowski was a postdoc in my lab that now has launched her own research program. For many years, I worked both in the brain injury stroke space as well as working with older adults with cognitive impairments. And she's really taken that theme and made it her own. So I'm going to speak to her work and give her credit. She really thought that the premise of working with people with mild cognitive impairment or mild dementia is less about improving their independence and more about slowing the decline. That if you can preserve a certain amount of ADL resilience, if you will, or mobility resilience with a strategy training and program, that's still a win. And so the focus for K Award was to adapt that program and identify what are the unique adaptations for that population, manualize those tests. She worked with stakeholders and a number of different entities. And what she learned was the biggest thing, again, the goal, plan, do, check didn't work for that group either. So she has a very simple strategy. The workbook becomes more important for them than it does even for my people. They need to refer back to their sessions. And the activities they work on, they're all community dwelling folks, right? So the activities they're working on are way more complex. So they have to build a little bit more scaffolding into breaking down the tasks and analyzing the performance. Those are the 3 adaptations that they've identified. And they also have to kind of build in a scheduling approach, some behavior activation strategies. So you're going to plan to do this between now and when I see you in 3 days. Talk to me about when you're going to do this. So kind of getting them to build it into their habits and routines as much as to analyze their performance. Those are some changes. She used those data because she found actually that there was significantly less decline over 1 year in cognitive instrumental activities of daily living in people who received strategy training versus enhanced usual care, which was essentially not a lot. And she got this R01 funded. And one of the cool things that she added to it, she has an exploratory hypothesis. All of her people have amnestic MCI by inclusion. They're adjudicated by our Alzheimer's Disease Research Center. And then what she's doing is they're all getting amyloid imaging to look at how much amyloid burden they have, with a working hypothesis that the amyloid burden might explain the difference between responders and non-responders. And it may or may not, but that she's going to test that hypothesis. And even if that hypothesis is not supported, that's still an interesting finding. So there's no losing in that deal. So she is 2.5 years into that. and it's all blinded, so I can't tell you anything about what's going on. She has adapted that for a teledelivery model. And as in the pandemic, she's, I think, lost 1 month of data collection and has found a way to do the rest. But that's something that's going on. Will it work? You'll have to ask me back in a few years, or invite Jolene would be even better to talk about her work. Yeah, but I don't recommend it. We say moderate to severe dementia, but we've actually shown that people with semantic memory, moderate to severe semantic memory deficits or declarative memory deficits, depending on your school of training, have trouble. And so those are the folks that we would refer to as having anterograde amnesia. They have trouble learning new facts, figures, knowledge. We saw that in our aphasia study as well. And we know from literature in folks with amnestic amnesia after TBI that they actually do better with an error-less learning approach, not an error-full learning approach. You're gonna tap their implicit learning system, and you're gonna build a habit without necessarily having them overanalyze their performance, because that actually builds in a perturbation to their learning. So those are folks I would not use this approach with.
Very, very interesting. I have another question for you. So we think about errorless learning as being important.
I didn't even see that, Jan. Thank you for that question.
However, you talk about the importance of learning through errors before the end of the presentation.
Yeah, so let's talk about that. My view is that one's not better than the other. They have different applications. So errorless learning is about building habit, motor memory, if you will, right? Just by rehearsing again and again and again. And it is a very effective strategy, particularly with complex motor tasks, to help someone learn. And we know that people with severe dementia can learn through errorless learning. One of the studies in the 80s that my mentors, Joan Rogers and Margot Holm, did is they went into nursing homes with people with severe dementia and behavioral disruptions. And they learned that if they standardize their morning routine and train the PCT to lay out the materials in the same way, in the same order, and standardize that, they actually decrease the need for psychotropic medication and reduce behavioral disruption through that habit routine. Here's the thing, errorless learning does not generalize though. It is task-specific practice, which has a place and is highly valuable. But if the goal is some sort of generalization, by practicing using my water pick, I learn something that I can apply to when I'm cooking a meal, error-full learning becomes an important piece. It's just not indicated from people who can't benefit from it. And I would say it's those folks with severe semantic memory deficits. That's what I don't have enough data to tell you that's definitive, but we definitely have a signal to suggest that might be the defining factor. Does that make sense?
Yes, to me. I don't know if Jan has any further follow-up questions to that. Let's see.
Oh, they're rolling in now.
Oh, they are. Let's see. Let's see where. Okay, so this was an interesting talk. It was very applicable to school therapy, where policy supports the focus on supporting students in meaningful school tasks in context. My question is about internal validity. You probably have data over 13 years. I think about the characteristics.
Yeah.
The therapist and the clients. The therapists are doing client-centered care. Perhaps therapists are switching to direct strategies or strategy training based upon client and therapist characteristics.
Yeah, it's a really insightful question, Sharon, and it's a complex answer. Actually, first of all, I need to tell you that most of these theories come from the educational science, right? It comes from educational research and how people learn, and we've just leveraged that. So it makes great sense that you see that in school-based treatment because they've been ahead of the game. Rehab has been slow. We don't necessarily train therapists to think about how people learn, and shame on us, because it's like a core function of what we do, right? So number one, I think that's really relevant. This issue about whether people use strategy training or direct skill training based on the characteristics of the therapist or the patient, I would say our data don't support that. What we have found is that we've been able to we've trained over 50 therapists, PTs, OTs, speech therapists. We had a couple of rehab counselors and rehab nurses. So we've trained across disciplines. And we have found that we've been able to train everybody in strategy training. And it's a problem that once they learn it, they can't go back. So I can't use them in a future trial because they screw up my data. I think direct skill training is our default position, just like the way we do education in the classroom. We feel that it's efficient for the teacher to get up and unload a bunch of information that students would automatically learn. And we do the same thing in practice. I'm going to tell you what to do and you're going to automatically learn it. But everything that we've learned about active learning and engaging learners tells us that's contrary to the notion of how people learn. It's just, we think it takes us less time to do direct skill training. And my parallel to this is, any of you who are parents know that, you know, it's like getting ready when you're not in the pandemic and going to work and getting the kids through the morning routine and getting them out the door, right? And what do? You just harp on the same thing every day. If you were to take a moment and a few days, a few painful days, to get them to anticipate and problem solve, you're no longer doing that harping. That goes away. They learn and apply the skill, generally speaking, with good strategies. So I think this notion that we have, even what I'm doing right now, is exposing people to ideas. It's stimulating ideas. It's not necessarily going to change the way you practice tomorrow. But if we sat down and we worked together, you would learn these strategies and you would find that it has a place and time. Now, in terms of switching from strategy training back to direct skill training, we conceptualize that in terms of where people are when they slide up and down the scale. And the best data that I have, I showed you a sample of 20, but we have more data where we see this variation within session based on task. It's been mostly task, and across sessions based on clients as they improve. We've not been able to correlate that with therapist characteristics. Nothing we've looked at has correlated. So it could be faulty methodology. I'm not sure. Maybe you can give us some ideas of what else we can look at, but the things we've picked so far have not lined up.
I have another question. As a new therapist, one that is still in school, do you think we need to fully understand direct skill training to get good at strategy training? Or do you feel like we can jump directly into strategy training?
I think you need to learn both skills, because there's bad direct skill training and there's good direct skill training. There's bad strategy training, there's good strategy training. I think that we have found new grads the easiest to train on strategy training. They pick it up faster. They've got no preconceived habits or notions. We don't have to break them of habits. They generally don't have, they're learning their confidence. And so, you know, they're willing to partner a little bit more with clients. And so we actually do train in both. We talk about when to use both. We find that they pick it up faster. We've had first-year students, our first-year graduates among our therapists. We've had 30-year graduates among our therapists. The only difference is how quickly they pick it up, to be honest with you. So do I think you should learn one before the other? I think you should learn them both. I think you should experience what they feel like and how they feel differently. And then I would recommend starting with a strategy training perspective and then scaling up to direct skill training if you need to. I mean, Helen's whole scaffolding of first ask, then tell, then coach, don't adjust, then make it obvious. You're still getting that direct skill training in. It's just not your first place that you start. Now, let me be clear. If I am transferring someone for the first time into a tub or out of the tub, I might do a little strategy training advanced to plan, but if we're in the middle of it and they're losing their balance, I'm not going to sit there and say, hold please, let's talk about what we could do differently. I'm going to downshift very quickly into direct skill training and say, put your foot here, sit down, and I'm going to take over, right? But I have a lot of practice with that kind of piece, and I know what I can and cannot do, what's safe and not safe for that client. So I think you have to learn both. Start with one, and you may early on in your career shift to direct skill training a little bit faster till you learn your boundaries and what you can manage, what you can't manage. So I wouldn't choose one over the other or one before the other. I would learn them together and apply them differently.
I have another question. What is the role that you think motor imagery and mental practice plays between treatment sessions in patients?
Yeah, I think that it's a fascinating question and something we have not systematically done, but we've used as a strategy, non-systematically. So I have no data on this, but sometimes that'll be a strategy when we're planning. We get them to try to manage in it. After they've debriefed and they're thinking about how they're going to apply it the next time we meet, which is usually the next day in inpatient rehab, think it through, walk it through. And we've even structured some motor imagery using motor imaging protocols, but we've done it, you know, based on when it made sense to, and maybe, you know, we've been non-systematic about it. I think it could be a really cool way to operationalize one of the strategies that you could embed in your strategy training set. We haven't been systematic about it.
I think you might have answered this, but does this approach work for people with aphasia? I think your data showed.
Yeah, but I didn't talk about how. So we, if anybody to include in our aphasia study, we just finished this study. It's just accepted in press 2 days ago. We included anyone that had any means of communication with us. If there was some way for us to understand them and there was some way for them to understand us, augmented communication, iPad, gesture, something, they were included. But anyone who had pure global aphasia, we did not include. And then we used supported communication strategies where we communicated in 2 or more modalities at the same time. So while I'm teaching the strategy, start, S is select, I'm drawing something or showing a picture that goes with it. And we taught our therapists how to speak in simple words, simple phrases, lots of pauses, and use these multiple strategies. So we actually got through less goals or less activities in compared to the non-aphasia folks, but we showed they made the same amount of gains in measures of independence when we controlled for initial stroke severity, NIH stroke scale, and initial FIM score. What we haven't done, to answer your question, Bob, is really analyze which of those strategies worked better for people who had more trouble understanding versus expressing. And we don't have a large enough sample to do that well, but we have a lot of video. So we have a SLP PhD student under Will Evans who's doing some evaluation of that to see at least if he can generate some hypotheses for us to test in a future study. But our therapist anecdotally noticed that certain augmented communication strategies or supported communication strategies work better with some people versus others. And it seems to be a little bit about expression and understanding. It also seems to be a little bit about what type of memory impairments they had. Those seem to be 3 things that we're taking a deeper look at. We have anecdotal observations at this point.
Another question is, can these strategies be used in all settings, like in acute settings, subacute settings, outpatient settings?
Great question.
And does the effectiveness vary in these different settings, as far as you know?
Okay, so I do not recommend this approach for acute settings. We know that we need a minimum dose of 7 for people to start to catch on and benefit. And if you get less than that, I think you're at risk of giving people not having enough practice to either be frustrated or unsafe. So I don't recommend, if you're not going to have a sufficient dose to get it a minimum of 7, I do not recommend it. And in acute care, that's rarely an option for you. So we've talked about what could you do in acute care, and we feel like a very simple activity card sort, 10 pictures, as a way of finding out what goals are, and then using that for a little bit of practice and assessment, self-assessment. You could do those pieces. But in terms of the strategy and the development, you just don't have enough time or dose to really make that a meaningful experience for the client. Subacute, outpatient, community-based studies, chronic, acute, chronic, like inpatient rehab or chronic, we've done all of those. Is it more effective in one versus the other? I can't answer that question because we've never done that comparative analysis. And it's not an easy analysis to do because we tend to use different measures in different settings, right? And inpatient rehab, measures of basic self-care and mobility make great sense because that's where you expect to see the biggest change. By the time folks are getting to outpatient or community, they've ceilinged out on that. We're using different measures to assess their baseline. So to do a comparison of apples to apples would be tricky. We'd have to think about what would be the unified variable that doesn't ceiling out. And I tackling that for another reason for our health system. I know we've looked at promise measures, IRT-based measures where you can scale because the scaling has already been done. I don't have any data to build off of that to answer the question, but it's something we've thought about.
I was curious if you looked at any outcomes, more distal outcomes like length of stay.
We have health system outcomes?
Yes.
Yeah, well, we see no difference in length of stay, which is good. It's not taking them longer, so that's good.
That's good.
No differences in length of stay. We have a signal for rehospitalization, less rehospitalization. We have a signal for less nursing home placement, or if they're going to nursing home, shorter nursing home placement. We have, and I'm saying signal because it's not statistically significant yet, but it looks like 0.06 kind of thing, but the effect sizes are meaningful. So I would say there's probably a subtle difference, but not a robust difference is what I would tell you. I think the biggest differences we see are 3, 6, and 12-month follow-ups in our studies. And so by that time, some of those health system outcomes have taken care of themselves. We do see statistically significant, less injurious falls in the home in the strategy training group versus the non-strategy training group. And I think it's that whole notion of non-supported gait training. I get that right, Dr. Sisto? So non-supported gait training, right? Or support. So you're giving people a little bit more freedom to test their balance, to test their boundaries. We're doing that cognitively. And so people have a better sense of where their risks are and their limits are by the time they're leaving the hospital, because we're giving them a little bit of freedom to do so.
Mm-hmm.
Did I get, is that right? I'm flubbing it, I think.
Body weight supported walking.
No, it comes from the Rehab Without Walls world, where you give people a little bit, rather than all the hands on someone when they're gait training, a little bit more room. And they don't always have a body weight supported sling on them. I've seen our therapists start to embrace this, where they just give them a little bit more room as they're walking, so they get a better sense of their balance and it's less controlled by the therapist.
Yeah.
So it's the same kind of idea. It's just as it relates to other activities.
Walking. Yeah. Mm-hmm. What about, I just lost this question.
Pediatrics.
What about pediatric population?
Yeah.
Yeah.
Helen Politeco would probably come and bop me on the head, because this work started in pediatrics and we generalized it to adults. Yes, I think it's not a carryover to pediatrics. That's where the work started. Again, I tell you, a lot of these are principles in educational settings. And so it made sense for a lot of the therapists who are working with educators to start testing these. So the original work in a lot of these areas, as it pulled into rehab, was happening in school-based practice. And that's where it started. And then it quickly spanned out to cerebral palsy, autism, Asperger's, folks on the spectrum. Dido Green's done some interesting work in the UK and Spain. Sylvia Rogers, the late Sylvia Rogers, did some wonderful work in Australia in this area. Helen Politeco has done a boatload of work in peds, and there are books after books after books on these applications. Acquired TBI, yes, we've seen this work applied to acquired TBI. We find they need a few more than 10 sessions. They tend to need more than 12 to 15 because they learn at a little slower pace. And we tend to start a little higher on that therapist control continuum and slide down because they tend to need a little bit more structure up front than some of our stroke clients. I'd put them in the same category as our folks with moderate to severe self-awareness impairments or neglect, anosognosia. It's a similar kind, they need a little bit more structure. But yes, there's been a boatload of studies in using these principles in TBI, even back to the 80s. You called it different names, but the principles are relevant, are apparent in the problem-solving therapy approaches, the metacognitive approaches.
Mm-hmm. Well, I think I have all of the questions posed.
7 o'clock.
Oh, I think I have one more. Is strategy training not applicable for, oh yeah, so we addressed that with the aphasia.
Yeah.
Yeah, I think we've addressed all the questions. So I wanted to thank you so much for sticking with us and answering all these questions off the cuff, so to speak. It was really interesting. And I thank all the participants who joined to listen to you and ask these very compelling questions.
Yes, thank you all.
Thank you. Take care, everyone.